Well, thank you all for attending, and I think this is an exciting presentation. I don't want to just focus on the things that you can read in all of the papers that have come out regarding immunogenicity, but sort of to push the envelope a little. You know, it's not just where we are, but where we should be going. So I think, as you all know, immunogenicity risk, like all other risks, is an amalgam of consequences and probability, the severity of the consequences and the likelihood that they will happen. And this has been better formalized by Sterling and Guy, who were really focusing on environmental issues, but they divided up incertitude about consequences into these four categories. And as far as risk goes, they've defined it as a situation in which the consequences are well defined and you actually have some basis for the probabilities. And I think this is very useful, certainly distinguishes it from something like ignorance, where the consequences are poorly defined and you really don't know anything about the probabilities. So I think this is a useful construct. So let's jump right to the consequences. So obviously the most severe consequences of immune responses are those that are fatal or have severe morbidity. And with respect to that, immediate hypersensitivity responses can be devastating. And we see this typically when we administer proteins of non-human origin, such as a protein and asparaginase. They're not common. I don't mean to indicate that they're common, but they are almost uniformly come from proteins of non-human origin, or they are. It's a result of putting human proteins into people who are knockouts for that protein. So you see this with hemophilia B in particular, where there's a high percentage of anaphylaxis to factor IX in these patients, about 26%, which is very high. The second consequence, fatal consequence, is the development of neutralizing antibodies to life-saving therapeutics. And again, this is typically in patients who are knockouts, either for coagulation factors or for lysosomal enzymes. And so when you give these products back to patients who have the most severe genetic mutations and don't make the protein, their immune systems have never been exposed, they make these neutralizing antibodies, and it inhibits these life-saving therapeutics, and patients can die from this. The third category regards immune responses to protein therapeutics that are counterparts of endogenous proteins. And so when these endogenous proteins mediate a unique function, if you neutralize them, because the antibodies to the therapeutic cross-react on the endogenous, it can result in a deficiency syndrome, which can be devastating. And we've seen this in response to treatment with thrombopoietin, with erythropoietin. And there's an autoimmune disease in which antibodies to GM-CSF that neutralize this factor actually cause a terrible pulmonary disorder called pulmonary alveolar proteinosis, and it really is due to antibodies to GM-CSF, and we'll cover some of these a little bit later. So less severe consequences. So the diminished efficacy of highly effective therapeutic proteins, and you know, whereas this is a not as severe a consequence.